It's my distinct honor and privilege to introduce Dr. Dilip, a world-renowned clinical scientist, academic leader, and innovator in the field of interventional neurology and neurovascular therapeutics. Dr. Dilip currently serves as Professor of Clinical Neurology and Neurosurgery, Director of Interventional Neurology, and Co-Director of Endovascular Neurosurgery at the University of Miami and Jackson Memorial Hospital. He also directs the Neurological Stem Cell Platform at the Interdisciplinary Stem Cell Institute of the University of Miami. He's a pioneer in contribution towards regenerative approaches in neurological disease. Internationally recognized for his leadership in advancing acute ischemic stroke therapy, Dr. Yavagal has been a steering committee member of landmark randomized clinical trials, including the SWIFT Prime and Mr. Rescue studies, both pivotal in establishing modern standards of endovascular stroke care. He also co-authored the 2015 American Heart Association Guidelines on Endovascular Stroke Therapy, a milestone that transformed global stroke management practices. His contribution to the DAWN trial, published in the New England Journal of Medicine, extended the therapeutic window for mechanical thrombectomy and the treatment paradigm for late-presenting stroke patients. Beyond his academic and research achievement, Dr. Yavagal is the founder and the past president of Society for Vascular and Interventional Neurology, through which he has fostered global collaboration and education in the neurointerventional community. On this World Stroke Day, as we reflect upon the advancement and future directions in acute ischemic stroke management, it is indeed a privilege to welcome a visionary leader whose work continues to redefine standard of care and inspire millions worldwide. Please join me in warmly welcoming Dr. Dilip for delivering his oration. Welcome to you, sir.
It's really a privilege to give this oration at the Neurocritical Care Society of India talk on World Stroke Day, and I'm very touched always to be able to share my work and the advances that have occurred in acute stroke care with societies and colleagues in India, because there's just such a emotional and motherland connection that I have. I trained in KM Hospital in Mumbai. I went to medical school there and did internal medicine, and this is really a privilege. Thank you so much. I wanted to just share my disclosures. I'm a consultant for device companies that make thrombectomy devices. I don't have any royalties, and I'm supported by grants for my stem cell work. So I'd like to divide the talk into the thrombectomy approaches for early window of stroke, which is within 6 hours, and then talk about the evidence and the guidelines for the late window. And then, of course, there is really the continuous advances that have occurred for distal occlusions, for direct versus bridging therapy, and then for thrombectomy for basilar occlusion, and conclude with thrombectomy for tandem occlusions. All right, so the burden of stroke is really not lost on this audience. However, it's important to take a step back and just look at the global burden of stroke and how much attention has been paid, after which you realize that stroke is really a neglected pandemic. It's a global disease, and even though pandemics are strictly by definition infectious diseases, the fact that there is such a massive burden of 12 million strokes per year, 120 lakh strokes per year, 95 lakhs are ischemic strokes, and there are 7 million stroke-related deaths every year, and 143 million years of life lost due to stroke per year. This is bigger than most countries' populations, and it's really a staggering burden. And the most unfortunate part that pains us all is that 75% of all stroke deaths and 81% of total daily adjusted disability years are in developing countries. So the countries that have the least resources have the most burden of stroke, way disproportionate than is really fair. But what's even more important is that when the COVID pandemic hit, and over 2 years it caused 6 million deaths, the amount of attention, resources, and money that was put towards a pandemic was way more than has ever been done for stroke. And as I said, COVID is thankfully come and gone, but stroke continues, and yet the attention is very, very less. And so therefore, I like to call it the silent pandemic, where we need to bring attention of policymakers, health ministers, both not-for-profit and for-profit entities to pay attention to overcoming this burden of stroke. And thrombectomy, in a lot of ways, provides us that tool along with thrombolysis, especially in the acute stage. But also, when you talk to policymakers and non-physicians who are in healthcare, they really need to know numbers. And so we model the economic burden. And what we found, we published this, is the total annual global cost of stroke because of disability, because of stroke care for 10 and 20 years once the patient survives, and also the economic productivity that's lost, leads to a staggering global burden of $2 trillion. This is 1.6% of all global GDP. And so these numbers are important to bring out, that if we can invest in overcoming stroke, we would be saving a lot of money by preventing disability and death. And India, for being a low middle income country, and the genetics and the diet and the risk factor control being poor, is again disproportionately burdened with cardiovascular disease, as we know. These are old numbers. Even in 2005, India lost $8.7 billion. But the staggering number is here. India would lose $237 billion from a loss of productivity just in the 10-year period, 2005 to 2015, was what was calculated. So, the economic cost in India, just like in the rest of the world, is quite staggering. But we finally can prevent disability and death, because even though large vessel occlusions, which are the occlusions in the internal carotid artery or the middle cerebral artery or the basilar artery, even though they are 20 to 30% of all stroke, they contribute to 60 to 70% of all stroke, death, and disability. And the benefit that thrombectomy, along with thrombolysis, with or without thrombolysis, provides can really overcome that in over 50% of patients, as I will show you. So this is a case vignette I like to show. This is one of my first cases with a stent retriever that I performed at Jackson Memorial Hospital. The 63-year-old lady who had AFib discontinued her Coumadin due to gynecological bleeding, presented with 2-hour symptoms of right MCA syndrome. She was weak on the left side of the body. The NIHSS was 8. And as you know, this is a scale from 0 to 42. And what you see at 2 hours is a common scenario where the CT actually looks almost normal. If you pay close attention, there is loss of gray white junction in the right frontal lobe, whereas the gray white on the left side, for comparison, is nicely preserved. And these are called early ischemic changes. And this is what allows us to calculate what's called the aspect score. This aspect score, because of subtracting 1, and we'll go over that a little bit later, is 8. There's 2 areas. This is the M1 area that has a loss, and then there is a slight caudate head loss. As you can see, it's not as crisp. And also there is a loss of gray white junction at the external capsule. So it's actually a 7 aspects. And so it tells you that this is a patient who has early ischemic changes but is above the cutoff of 6, which was used in the trials, and the total score is 10, 10 being the best. And so this patient was a candidate for thrombectomy. And we also, sorry, this arrow is not placed properly, saw that there was a clot on the non-contrast CT seen with a hyperdense sign on what is called a MIP image, maximum intensity projection image, in the right distal M1 at the bifurcation. This is the Sylvian fissure, and so you can see that there is a clot there. And the next step would be a CT angiogram, but because we saw the hyperdense sign, in order to save time, and we'll go over why we tried to save time, we took her directly to angio, and I did a standard right internal carotid artery angiogram. This is the AP view. And you can see that the contrast goes up in the my catheter is down below, as you know, and the contrast goes up into the upper cervical ICA, the petrous ICA, the cavernous ICA, and then the supraclinoid ICA. And the medial branch, which is the ACA, is fine. And this is for all our trainees that may be watching this. But the right M1 stops. And this is what's called a cutoff, a large vessel occlusion. And this indicates that there is a thrombus sitting here that prevents flow into the MCA branches. How does that look on the lateral? You can see the ACA. Again, let's go over the segments here. This is the upper cervical, the petrous ICA, the cavernous ICA. This is all medical school anatomy that you can see angiographically. And this is a supraclinoid ICA. The clinoid is here. So this is a supraclinoid. And the ACA flows nicely, but all the MCA branches are completely lacking blood. And that's because the MCA, the M1 that's coming towards us on the lateral, is blocked, as I showed you. We took a microcatheter, and this is the standard step. It is a 27,000th of an inch microcatheter through a guide catheter in the cervical carotid that is navigated over a 14,000th of an inch wire, and we cross the M1 here and go beyond the clot so that we can then bring up a stent retriever, and you can see that in this animation. I think many of you have seen this because we've been playing this for more than 10 years now. But on the other hand, it still bears repeating to get an idea of how thrombectomy is actually done. This 14,000 inch wire makes it very safe to cross the thrombus. And that, is successful in 99% of the times, which is really the basis of thrombectomy. You can cross it and then bring a micro catheter over it, take the micro wire out, and then bring up your stent retriever. As you know, the other technique is to bring up a aspiration catheter instead of a stent retriever, or along with the stent retriever. And with the aspiration catheter, you can bring it up to the face of the clot. One applies suction and pulls the clot out. But this is the classical stent retriever that allows us to deploy the stent in the thrombus, and that entangles or engages the clot on the outer surface of the stent, and in fact leads to an immediate reperfusion even as we deploy it in more than 80% of the cases. Once we let the stent retriever be in the clot for about 5 minutes, we inflate the balloon, if we're using a balloon glide, to have flow arrest, and then retrieve the clot and the stent at the same time. And so that's what we did. And here is a still picture showing the entanglement of the clot outside on the outer surface. This is how it comes out. And this is now seen in over 90% of patients. We are able to remove the clot. It may take more than one pass, but what I was also trying to show is in other cases, I didn't do it in this case, you can bring up a aspiration catheter along with a stent retriever. The aspiration catheter stays at the face of the clot. So you add a suction to the stent retrieval and increase the chances of what's called a first pass reperfusion. In other words, you want to do this in one attempt, which correlates with the best outcomes. In any case, we did the stent retriever. This was a 2012 case, so long time back, but one of our first cases. So it's a landmark case for my practice, and we got a complete reperfusion. You can see all these branches are now reperfused because we've removed the clot from the distal M1, and the speed in this case was one of the fastest at that time. Last known well was 245. Patient was brought to our service at just within 2 hours to Jackson Memorial. The CT was done within the hour, or actually within about 35 minutes. Groin puncture was done within an hour or less than an hour of the CT, and complete recanalization was obtained within 52 minutes. And this has now been cut down to half or less than half, and we can get all of these times down, and we try to get to complete reperfusion, or at least the first pass, within 90 minutes from door to doing the first pass. We do it in 90 minutes. What you see here is a beautiful reperfusion or revascularization of the previously occluded MCA. This is the final stroke. As you know, the entire MCA was at risk here, and that was salvaged except for what was showing an early ischemic change on CT. And so this is the power that started to be seen of removing the clot in the late 90s and in the early 2000s, and it took a full 20 years of clinical trials to finally in 2015 show with 6 trials. I don't have the 6th one here, that indeed this is not just happening in a few cases, but in large randomized clinical trials, the patients who got thrombectomy within 6 hours did significantly better as compared to patients who only got IV thrombolysis or or only medical therapy. And this was seen in all 6 trials, and that changed the face of stroke care. In MR Clean, the endovascular arm had 31% good outcomes, meaning that patients were completely independent at 90 days, whereas medical therapy only 19%. And the best result was in Extend IA. 71% of patients had a good outcome. There was perfusion imaging used here, but it is also a very small trial, and we know that small trials can give you a large effects. And the reason this trial was small and other trials were also less than 500 is because once MR Clean showed this dramatic benefit, the other trials were all prematurely stopped for ethical reasons, so that we didn't randomize patients anymore. But every trial, despite stopping early, came positive. The symptomatic hemorrhage rate, symptomatic ICH, was very acceptable and not different between the endovascular arm and the medical arm. 6% in MR Clean, only 1% in SIF prime. So range from 1% to 6%. And the number needed to treat, which is an indicator of how powerful a therapy was as low as 3 in Extend IA. And with adjustment, the number needed to treat was only about 2.7, which is one of the most powerful therapies in all of medicine. So in 2015, we showed that thrombectomy works beyond doubt within 6 hours. And the number needed to treat, again, is here. You can see that only if we treated 3 patients in Extend IA, 1 would be completely independent. And just to give you an comparison, when you do STEMI, you need to treat 25 patients to prevent one heart failure. And so this is something that is really been a major advance. And you can see here again the comparison. So if you look at care of AIS patient in the stroke unit, you need to treat 18 patients to get one patient independent. Aspirin, you need to treat 83 patients to prevent one stroke, and arthrectomy, especially for asymptomatic, you need 100 patients. So as compared to all of those, is really a very powerful therapy. And even as compared to IV TPA, 8, you need to treat 8 in the 3 hours or 14 in 4.5 hours to get an independent outcome. So the benefit was always expected, but I think for a large number of us, the magnitude of benefit was beyond our wildest dreams. And that's the best thing that we can offer our patients. When you looked at subgroups, whether the patient was randomized after 2 hours or within 2 hours, the benefit was the same. Whether they got TPA, yes, which was the majority of the patients, and this is in the ESCAPE. Sorry, this is in the MR Clean trial. Whether they got TPA or not, the benefit was seen in both groups. And the most unexpected result for most people was that whether the patient was under 80 or above 80, both groups had a clear benefit of thrombectomy. And so this really took off any upper age limit in performing thrombectomy. And this is a great example of a 90-year-old that I treated. They came in with the M1 occlusion on the left side. They were independent at home. They came in within, I believe, about 2 hours of symptom onset. And they were, the CT was done within 12 minutes. Door to groin puncture was 64 minutes, and door to reperfusion was 150 minutes. And they they had full revascularization. They had a starting NIHS of 18, but a final NIHS of 0 just within 24 hours. And the patient went back home without needing any rehab. And so this changed the guidelines. We wrote this as one of the fastest guidelines. With Dr. Powers leading the guideline in 2015. And basically, the guideline said that based on this evidence, patients should receive mechanical thrombectomy with a stent retriever if they met the following conditions. Their pre-stroke, they were independent, a score of 0 or 1, modified Rankin scale. The causative occlusion was an internal carotid or M1 segment, and they were more than 18 years of age. NIHS score above 6, aspects above 6, and the treatment could be initiated within 6 hours of symptom onset. Although the benefits are uncertain, the use of mechanical thrombectomy may be reasonable for M2 or M3 segments, and this is now going to be modified with the MEVO trials. We'll talk about that. And then we also said that there were very few patients of basilar occlusion that got included in some of the trials. So a 2B guideline for both the distal branches and the basilar was given in those guidelines, and that changed a few years after 2015, as I will show you. And so this therapy got a wide adoption all over the world after these guidelines. This is a 26-year-old that I treated. She had a PFO that was discovered later and closed, but she had was having breakfast with her boyfriend and suddenly started dropping things and missing her words. And you can see the left M1 is occluded again, and the branches on the lateral are not seen on the MCA. I revascularized her within one pass with a stent retriever, and she recovered on the table, where she started moving her right side, started speaking, and did really well. And what was clear from a meta-analysis of the 6 landmark trials in the Hermes analysis was that even within the 6 hours, earlier treatment is better. And every few minutes, the outcome rates go down up to about 7.5 hours. Some ESCAPE trial was about 12 hours. So this goes beyond 6 hours, but at 7.5 hours, the benefit is gone. And so this is where the clear correlation of time to reperfusion was seen. The outcomes in thrombectomy in the early window are highly, highly time sensitive. And what we found that with every 1,000 patients treated, even a 15-minute faster door to reperfusion leads to 39 more patients being less disabled. Very, very tangible number in Miami now across about 12 hospitals. We treat close to 1,500 patients a year with thrombectomy. And so cutting down minute by minute is making a difference for these, more than 50 patients in Miami if you can do things faster. And so all the protocols are geared towards doing the procedure in the fastest time possible. And so we really have worked on the systems continuously with all the like a race car team, where we bring the patient to the ED arrival to CT complete within 20 minutes, TPA given within 3 minutes of the CT, groin puncture done within about 20 minutes, and reperfusion from 11:10 to 11:40. Within 30 minutes, we have the clot out and the reperfused, and that leads to such a good outcome. I'm going to rush here. So 0 to 6 hours, the only imaging that's recommended by the guidelines is that emergency imaging of the brain is recommended before initiating any treatment for acute stroke. In class 1 level of evidence A, the highest recommendation, highest level of evidence. In most instances, a non-enhanced CT will provide the necessary information to make decisions about emergency management. It was the same guideline in 2013. But the reason that this is in the guideline is because CT is so widely available, and the trials also use CT in 90% of patients. And you can see that if you look for early ischemic changes at the ganglionic and the supraganglionic level in these 10 areas, and I won't go over each of the areas, but you look at the subcortical and cortical areas, and this is all MCA geared. You can subtract 1 out of 10 for every early ischemic change. And so again, the lowest score is 0. There's almost complete early ischemia in the MCA territory, versus 10 being the best, no early ischemic changes. And as long as the patient score is above 6, you can expect a good outcome from thrombectomy. The other imaging that's recommended is a CTA or an MRA. And so that's also a class 1, level 1. I'm going a little fast in the interest of time. And the benefits of additional imaging in the early window, such as CT perfusion, are unknown, because this was not recommended in 5 out of the 6 trials. Only Extend IA in Australia use CT perfusion imaging. So we do not do CT perfusion. We do not want to waste time when it's not really making a difference in the outcome. And we only use it in the late window. And so the early window was conquered very well in 2015. But the investigators, and I am very proud to say that we were on the steering committee of Swift Prime, and we enrolled a number of patients at Swift Prime from Jackson Memorial and University of Miami, and then I was on the site PI for Dawn, which we immediately got to working after the 2015 trials. And the reason that the late window was targeted was because of this very important concept of core and penumbra, where a central area of the brain in the ischemic territory starts to be irreversibly infarcted within the first minutes to hour or two. But there is a large area in a number of patients, or a significantly large area, I should say, called the penumbra. And we learned this all in medical school, but this is a real-time phenomena that can be imaged now, that can be salvaged by reperfusion. And salvaging the penumbra in a large number of patients who have penumbra to salvage can significantly reduce disability. And this is the hypothesis that the late window trials worked on. And we always want to balance time delays with additional imaging. But given that the Hermes trial showed, as I showed you in the graph, that there is a continuous progression of ischemia. Right here, there is a continuous progression of ischemia. In the late window, beyond the 6 hours, or here 7.5 hours, we wanted to only choose patients for the studies that had not progressed and had penumbral tissue that could be salvaged. And so in the late window, what we have is a need for either a diffusion-weighted imaging and a diffusion clinical mismatch, or this was in the DAWN trial, or a CT perfusion that showed us the core, and there was a core clinical mismatch. And in the diffuse study, you had to have CT perfusion or MR perfusion, as I'll show you. So this is a case, a 62-year-old who woke up, and most of the late window patients are wake-up strokes, who had a severe right MCA syndrome on waking up. He was seen 10 p.m. before going to bed, woke up with an NIHS of 20, and you can see this is a right MCA stroke, which is at this point small, but the entire right MCA is at risk because the M1 origin itself is occluded. And the phenomena that that helps so many patients, even in the late window, is the phenomena of collaterals. So even though the M1 is blocked, in a number of patients, the collaterals keep the blood flow going and the progression is slower. Some patients, about 30% or 40%, are unlucky and don't have good collaterals, and they progress even in the first 4 hours. There is no tissue to salvage. But the target of the late window is really the slow progressors, as they are called. And in fact, trials have now started, and we are part of trials that are starting to enroll even beyond 24 hours. These are still minority of patients, but slow progressors can go beyond even 1 to 2 days in minority of patients. And the idea is that we reperfuse in those patients by selecting them for salvageable penumbra. And here is the result. At 90 days, 48% of patients with that salvageable penumbra in the DAWN trial were independent at 90 days. And only 13% of patients with medical management were independent if they did not get thrombectomy. Clearly superior outcome in the late window with thrombectomy. The treatment benefit was highly significant, and the number needed to treat was actually even lower than the Extend-IA trial of 2.8. So in patients in the late window who have salvageable penumbra, the benefit of thrombectomy is even higher. The symptomatic hemorrhage rate was again very acceptable, 6%, and it was not statistically significantly more. It was not statistically any different from the control group, even though numerically it was higher. And the result was replicated by the diffuse study, which mandated perfusion imaging in DAWN. If you'd had a DWI, you did not need perfusion. But here, the criteria was a NIHS of more than 6. DAWN needed NIHS of more than 10. But the window was 16 hours in diffuse. Baseline MRS had to be less than 2. IC or M1 occlusion. The core volume was actually quite a bit higher. That was allowed in the diffuse trial, up to 70 cc's. The mismatch ratio, which is the penumbral volume divided by the core volume, had to be above 1.8, or at least a 15 cc penumbra in this on CT perfusion, and that led to again a clear superiority being seen. A 45% of patients who got thrombectomy in the diffuse trial showed a independent outcome at 90 days, as compared to only 17% without thrombectomy. All the subgroups were positive. Age was not a barrier. Patients above the age of 80 also had clear benefit, as did below 80. So the guidelines were changed again in 2018. Because Dawn was up to 16 hours, the level 1A evidence guideline is for 16 hours. And in patients selected beyond 16 to 24 hours, it's a 2A recommendation. But in practice, it is really followed as a standard of care up to 24 hours. The imaging selection guideline is that in selected patients with acute ischemic stroke within 6 to 24 hours of last known normal, who have a large vessel occlusion in the anterior circulation, obtaining CT perfusion, DWMRI or MR perfusion is recommended to aid patient selection, level 1A. And so this is another case, vignette, 75-year-old gentleman with vascular risk factors, right MCA syndrome, NIHS of 16, MRS of 0 at baseline, right MN occlusion, last seen 14 hours ago. You can see there is actually no core, because this patient likely has a lot of collaterals. Core volume is only 0, but 77 cc's of penumbra. And so this is a highly salvageable patient. We took the patient to angio, right M1 is cut off. We did thrombectomy, and the NIHSs went down from 24 to 4. From 16 to 4 within 24 hours. We did what's called a combined technique. We used a stent retriever or a clot retriever. In this case, it was stent retriever solitaire and a aspiration catheter 068 together. And this is what happens. You bring up you deploy the stent retriever first. You also bring up an aspiration catheter to the face of the clot and remove the clot. All right, I'm going to speed up a little bit in the interest of time. Distal occlusions, so beyond M1 or beyond the basilar in the posterior circulation, are not uncommon. They comprise about 30% of all stroke, and they can cause very disabling deficits. 79-year-old who presented with a right facial droop, slurred speech, and numbness of the right arm, and the NIHSS was 6. They came within 2 hours, and they had subdural hemorrhage, so no TPA. And what we saw was a M2 occlusion. And the problem is that about 30% of these patients can get a lot worse if you don't intervene. And so the exam improved initially, but then they they still were taken to the angio suite because we were concerned that the M2 occlusion would lead to a worsening, and we did a perfusion imaging. You can see that the mean transit time shows a pretty large area at risk. So we did a angio, and we have to be more careful because here you can't see the clear cutoff in the distal occlusions. We have to blindly enter the M2, and you can see once we enter the M2 and deploy a stent retriever, that branch is open. We got the clot out, and this is the final reperfusion, and it's a Tiki 2B, not C. And this is the post thrombectomy. We have no clear stroke on CT, and they did quite well. And so we have a ability technically to do thrombectomy in the distal areas. However, the complication rates can be higher. A 66-year-old male who presented with leg weakness had a ACA occlusion in the A3 segment. We went up with a stent retriever, a smaller stent retriever, and we use what are called baby stent retrievers, so smaller diameter in the distal occlusion. We did a successful thrombectomy, but had a hemorrhage. So this is where distal occlusions, or what are called medium vessel occlusions, have a higher risk of hemorrhage in the range of about 7-8%. And the benefit is not as good. So the MIVO trials, which I'm not showing in the interest of time, 4 of them now, if I remember correctly, did not show clear superiority of thrombectomy. So right now we are not targeting distal occlusions or medium vessel occlusions, and the field is evolving to get better devices that are not as traumatic, and also select patients better, and only select patients with a higher deficit. The main difference between the M1 and the ICA or the basilar and beyond the M1 is that the vessels are not as well anchored. So there is a lot of movement when you try to aspirate or remove a clot, and that movement gives rise to the higher risk of hemorrhage. And also the ability to pull the clot out, and really I think this is the main reason, is not as great because the vessels are not well anchored. And so the physics of distal occlusions or medium vessel occlusions is not as favorable to thrombectomy as proximal occlusions. I'm going to move to bridging. And what we saw is that the field started to really think about whether we should even give TPA at all if the patient is a candidate for thrombectomy. The rationale is that when you give TPA, it can soften the clot, it can lyse distal thrombi, and especially if the patient is being transferred, you want to start dissolving the clot, but also it can lead to a higher first pass effect and a higher rate of successful reperfusion. But the downsides, which is why you can think of direct thrombectomy and avoid thrombolysis, is IVT, especially TNK, can lyse the M1 clot and make it a M2 occlusion. And that's harder to retrieve, as we just spoke. While it may allow, and if you don't do TPA, you could do faster door to groin puncture times. You can potentially reduce the risk of periprocedural hemorrhage, and of course the cost is lower. But this is what the trial showed. DEFT, direct empty, MR clean, and skip all showed that bridging was really, or I should say that the thrombectomy, direct thrombectomy, was not non-inferior to combination therapy. And the superiority trial again did not show a clear superiority. And you can see the SWIFT direct results. MRS was 57% with direct thrombectomy and 65% with bridging therapy. And even though the hemorrhage rates were no lower and the reperfusion rates were also similar, the functional improvement was not statistically significant. And so the direct mechanical thrombectomy, where we do not give TPA, has not shown any superiority. And in fact, bridging, which is TPA plus thrombectomy or TNK plus thrombectomy, is favored in the meta-analysis. Again, this is not based on a clear superiority, but on the other hand, direct thrombectomy is not non-inferior, meaning that endovascular therapy is not by itself, without thrombolysis, if the patient is eligible, is not recommended. If the patient is eligible for thrombolysis, these trials show that they should be getting the thrombolysis and getting the thrombectomy. Moving to basilar occlusions, we started with the BEST trial that did not show a clear superiority, but a trend. But then the ATTENTION trial, which is 0 to 6 hours in China, and the BAOCHE both clearly showed that basilar thrombectomy leads to a 46% improvement, whereas medical therapy only has 24% improvement. And so statistically significant, highly beneficial results. So basilar thrombectomy is now going to be in the guidelines as 1A. It's already in practice for the last 2 years. And then I'm going to finish with tandem occlusions. These are one of the toughest cases, because you have an occlusion in the neck at the carotid and an occlusion in the ICA or M1, or in the posterior circulation, an occlusion at the vertebral artery origin and a occlusion in the basilar. And the initial meta-analysis showed intervention was superior, and a randomized trial is going on right now called Picasso. But the meta-analysis showed that even though these are tough cases, intervention leads to a superior outcome. And so we practice this as the first line where we do thrombectomy in these patients. You can see here, in this case, the ICA is occluded, and also the M1 is occluded on CTA. So when we go in these cases to thrombectomy, we cross the occlusion with the microsystem, start giving TPA, and we can revascularize first, and on the way out do a angioplasty or stent. But most of the time we do the stent or the angioplasty on the way up, because if you don't do a stent, most of the time just with angioplasty, after a few minutes after doing angioplasty, the carotid starts to close down again. And so it's not clear whether we should put the stent first in the carotid and then open the occlusion, or the other way around. So that's also being tested in the Picasso trial. But I practice the stent first approach, where I put a stent in 90% plus of my tandem occlusions in the carotid first, and then go up and do the thrombectomy. So this is the workflow and guidelines in our practice at Jackson Memorial. All patients within 4.5 hours get a TPA unless there is a contraindication, and get a CT-CTA. And if they are if their aspects is above 6, they go to thrombectomy. Beyond 6 hours, no thrombolysis. But if they have aspects of 6 or more, they are taken to thrombectomy. And then wake up, we do perfusion imaging. And beyond 6 hours, we do perfusion imaging. I did not have time to cover large core occlusion or large core infarction, I should say, because of the interest of time. But a number of large core studies have come positive, about 6 of them now. And so we are doing a thrombectomy even in the large core, unless the patient is above 85 years of age, where there is even though the trials didn't show it, but with thrombectomy, the results are only about, in all ages, 20% of patients become independent after thrombectomy in large core infarctions, meaning the aspects is less than 6. And without thrombectomy, only about 10% or less have an independent outcome. So thrombectomy has been clearly shown to be superior, even in aspects below 6, but the magnitude of benefit is a lot lower than in a small core infarction. And so this is, again, advance, and the guidelines are changing to recommend thrombectomy as a 1A guideline for large core also. And I'm sorry, in the interest of time, I did not get a chance to cover it. And then the last slide is on general anesthesia versus conscious sedation. There is an update just from a few days ago where the SIGA trial showed that that general anesthesia has superior outcomes as compared to sedation. Number of studies were equivocal, but now we have a randomized trial, SIGA, SEGA, published in JAMA, that shows superiority. So our practice for the last 12 years has been general anesthesia for all our thrombectomy cases. So in summary, thrombectomy for large vessel occlusion is among the most powerful and beneficial treatments in medicine. Outcomes from thrombectomy are extremely time sensitive, especially in the early window, in the 6-hour window. And the impact of delays is unlike any emergency that we are used to. Contribution of patient selection strategies to efficacy and safety has to be weighed against delay in minutes. I know in India, MRI is the default imaging, but MRI always takes longer. So we have to really calculate from our data and continuously decide whether any imaging that we do is causing undue delay. And so selection with CT-CTA is a class 1 recommendation. CT perfusion for EVT less than 6 hours. CT perfusion or MRI DWI are required beyond 6 hours. And substantial reperfusion should be the goal of thrombectomy. We didn't get a chance to go into this in detail, but the interventionalist has to aim for a 50% or more reperfusion. Just getting one branch open, less than 50% reperfusion, is not going to lead to an independent outcome. So Of course, going beyond 4 passes can also be dangerous and futile. But the goal of your technique should be to get at least 50% reperfusion or more, and ideally 100% in the first pass. General anesthesia leads to superior outcomes in the SIGA trial, which we didn't have time to go into. But one big area we didn't cover is that substantial knee advances in acute stroke intervention are likely to come from advances in stroke systems of care, because we need the patient from their home where they have had a stroke or outside to reperfusion in as short a time as possible to get the best outcomes. So mobile stroke units, telemedicine, and having a stroke system of care in a city or a district ahead of time is really the only way to scale this benefit to thousands and thousands of patients. A new generation thrombectomy device are likely to change the scenario with distal occlusions and increase the first pass rate. And my other area of research in the laboratory is cellular therapy, which we can talk about another time. They are needed to bring the rate of functional independent outcome from 50% to closer to 100%. So we are looking with very promising results to add intraarterial stem cells after thrombectomy. Thank you so much. I hope this is useful, and you will see some of the question answers in the other session. Thank you so much.
My first question to you is, how are the recent imaging modalities, especially the AI-based modalities and imaging techniques which have come, how has it helped in the decision-making in acute ischemic stroke?
It's a great question. And as I showed in a few of my cases, the use of CT perfusion, especially because of the wide availability of CT, and in a few countries, I think including India, MR perfusion has really become a standard selection, especially in the late window of ischemic stroke, large vessel occlusion. Again, that would be the 6 to 24-hour window. Countries like Australia actually seem to have a standard where they do CT perfusion or sometimes MR perfusion, I guess. But I think they mainly do CT perfusion for all comers, early or late window, because they also use it to see where the location of the occlusion may be and some other uses. But the main utility is really in selecting patients in the late window who are eligible for thrombectomy per guidelines. And those guidelines and those selection criteria are based on 2 studies, the DAWN trial and the DIFFUSE trial, which used perfusion-based selection. While the DAWN criteria are a little bit involved, they have a mismatch between the core and the clinical NIHSS as a selection criteria. The diffuse criteria are easier to apply, and that's what a number of the AI-based software show, that if there is a core that is substantially lower than the penumbral tissue, then in general the patient is eligible for thrombectomy within 24 hours, because the chances of a good outcome are good, as there is tissue to salvage. The criteria for diffuse is at least a 15% more penumbral tissue as compared to core. All right, and that
Yes.
is really the main rule of thumb that is used. So the large core trials have changed the threshold that at least we use in practice at the University of Miami. We used to, before the large core trials, not take patients who have a core of more than 50 cc's, and definitely more than 70 cc's. But now, as long as there is a penumbra that's 15% more than the core, the patient is taken to thrombectomy at the University of Miami. So the guidelines haven't been changed since the large core trials. I believe they're going to be changed soon. But there, the core is typically 50 cc's or less, and the penumbral tissues 15% or more than the core. And this is something that the software calculates on the go. And so that's the biggest advantage of the software, that it tells you 30% mismatch, 80% mismatch. And that's where the AI-based analysis comes in. Right now it's simplistic, but the companies are incorporating it more and more to really also rule out ghost cores. I don't know how much that's been implemented. And by that I mean that sometimes the CT perfusion can overestimate the size of the core, and using certain parameters, AI can readjust that. I believe that's also being now incorporated. But those are really the changes that are happening with AI-based CT perfusion or MR perfusion software. And so to summarize my answer, which is quite long, is that currently, especially in the late window, AI-based CT perfusion or MR perfusion are extremely helpful in ruling out patients that have no salvageable penumbra, and ruling in patients and selecting patients who have salvageable brain tissue at their presentation, so that their thrombectomy has a decent chance of a good outcome.
Hello, sir. To just add on to that, I just want to ask you about the same thing in posterior circulation strokes, especially the basilar artery occlusions. Sometimes when we get these basilar artery occlusions, even within window period or out of window period, and especially when the data are not so great, it's only based on expert opinions. I would like to know, what is your personal experience on managing basilar artery occlusions when they come within 6 hours and after 6 to 4 hours? How do you select patients based on what criteria for thrombectomies?
It's a great question, Dr. Panaya. I agree with you that basilar artery occlusions, which are the large vessel occlusions in the posterior circulation, are a different, they behave differently with thrombectomy as compared to the anterior circulation stroke, which is not surprising. In other words, we are still learning how to select the best responders in the posterior circulation, and the data from the studies really is based on what is called a posterior circulation MRI aspects, and it's something that I don't use routinely. So I'll just tell you the criteria that we use, which is that anybody who is within 6 hours from their stroke symptom onset, if the CT shows a posterior circulation aspects of 6 or more, which is the lack of early ischemic changes to a large extent, then we take them right away to thrombectomy. But if they are beyond 6 hours, then we do either MRI or CT perfusion. And I find that MRI is much more predictive of the response to thrombectomy. And by that I mean that if the DWI shows a large amount of stroke, of ischemia in the brain stem, then their chances of having a good outcome are quite poor. And so the posterior circulation patient selection with MRI is quite helpful. You may or may not need MRI perfusion because the reality with posterior circulation strokes is that if you have a large part of the brainstem infarcted on diffusion weighted imaging, then the chances that even if you salvage the cerebellum or the thalamus, you probably will end up having a locked-in patient where the patient is awake, but they recover from the coma, but they are unable to move anything except for the eyes. So I think the point is that in posterior circulation stroke, one may use MRI-based selection more. This is outside the guidelines. The guideline-based selection is with aspects and with perfusion. But all in all, I have to say that at least in my practice, the selection for posterior circulation strokes is still evolving because we find it very hard to predict who is going to do well with a posterior circulation stroke thrombectomy. And so the use of MRI beyond 6 hours is something that I've been pursuing more and more to predict the prognosis. Having said that, especially in the US, where the patients, the patient is not charged for thrombectomy, their insurances, and if they don't have insurance, then they are not charged, and the system, subsidizes it. The thrombectomy is offered much more liberally because that's their only chance. Now, this is more of a practical approach rather than a scientific, a scientific guideline, because one can argue that in a posterior circulation stroke, if somebody's going to have a locked-in outcome, you shouldn't offer thrombectomy. But we haven't really built consensus towards that yet. I think that's why posterior circulation stroke thrombectomy is based on a couple of positive trials from China, and we need to learn more about this this approach. And so, to summarize, in the first 6 hours, we use CT aspects, and if their aspects are 6 or more in the posterior circulation, we take them to thrombectomy. And beyond 6 hours, we either use CT perfusion, which is not as satisfactory, or MRI, and rule out a big stroke, a big established infarct in the brainstem to select patients for thrombectomy.
Thank you, sir. So my next question is, there are so many trials about neuroprotective agents that have largely failed in the past. So are there new agents or strategies which are showing any promise regarding that aspect, sir?
Yeah, so my talk doesn't have the topic covered, but my research for the last 18 years is in the intra-arterial delivery of stem cells.
I read about that. That is something of your interest. When I read about you, so I saw that you are very interested in, your lab has stem cell therapy.
Right. So we can definitely talk about that briefly. So because the neuroprotective trials have failed, stem cells provide a major alternative and significant promise for neuroprotection of ischemic brain tissue. The science on the use of stem cells in stroke has accumulated since about 3 decades now, where in ischemic brain tissue, the adult stem cells that are the most commonly applied to clinical translation, which are the mesenchymal stem cells. And these are the type of stem cells that are derived from bone marrow or umbilical cord, and sometimes from adipose tissue. And these are the stem cells that are used in my research. They serve as drug factories, you could say, colloquially, quote unquote, drug factories, because they secrete a lot of neuroprotectant molecules, including anti-apoptosis molecules, and also a lot of anti-inflammatory cytokines that preserve or salvage the penumbral tissue over and above reperfusion. And so, in fact, the first-in-man patient that I haven't published but have presented, the publication is being submitted, but we have presented it a couple of times now, where we gave intraarterial mesenchymal stem cells, which are allogenic. They are from a healthy umbilical cord donor. I gave them at 5 days after a basilar occlusion, thrombectomy, where the patient unfortunately got locked in, as I was saying. And we saw not only a very safe delivery, the stem cells did not cause any adverse effects, but we saw a dramatic decrease in the size of the stroke at 10 days by about 60% on flare. And the patient recovered from being locked in to getting off the ventilator in about 6 months. And at about a year and a half, is now able to sit up and feed himself with his right hand. And so it's not a complete recovery, but way more than expected for a locked-in patient. And in the animal studies, in rats and in dogs, we have statistically significant benefit in functional recovery and stroke reduction. And so the promise of cell therapy, which instead of giving one molecule at a time, you are able to really allow what are typically repair cells to secrete a number of reparative molecules, and regenerative in the sense that these cells themselves don't become neurons, but they actually secrete growth factors that stimulate endogenous neurogenesis beyond what is spontaneously possible. And so that strategy now is being brought to phase 2 studies. We are applying for funding, and I think we will start with anterior circulation, but I think the application to both anterior and posterior circulation seems very promising.
Thank you, sir. Sir, so malignant cerebral edema is one very life-threatening condition. So how has the management of malignant cerebral edema evolved with the newer decompressive or the medical strategies?
Yeah, I have to say that my focus now, even though I'm neurocritical care trained, I haven't been practicing focused neurocritical care for the last 10 years or so, because I'm focused on neurointervention in my basic research. But I can tell you that, firstly, the incidence of malignant cerebral edema has really come down and there are good papers that I don't have the exact numbers in mind, but in M1 occlusions, thrombectomy has reduced the incidence of malignant cerebral edema, I think, by more than 30 or 40%. So the incidence itself has gone down. And if you look at the large core trials, the thrombectomy arm, even though the infarct may evolve into a large infarct, the malignant cerebral edema incidence rates were significantly lower in the thrombectomy arm. So that's the first thing, is that reperfusion therapy with thrombectomy has brought down the rates. Secondly, the medical therapy, certainly with 3% normal saline and with a bolus of hypertonic saline, 21%, has continued and has probably become more and more used in these thrombectomy patients who may not need a hemicraniectomy. And then the phase 2 studies of gliburide, which is a anti. I don't think I have that drug right. Actually, I'll have to correct the drug because I don't follow that literature. So I think I have the drug wrong. But there are trials of anti-edema medications that have progressed that I think in the future may have approval to decrease edema. And then the last thing I'll say is that the hemicraniectomy is still offered with a low threshold post thrombectomy, where we want to avoid brain herniation or uncle herniation. And so as long as the patient is below 70 years of age and has a reasonable chance of recovery to at least MRS of 3, we offer a hemicraniectomy. But I don't know that surgically, at least at my center at the University of Miami, we've changed the actual approach to hemicraniectomy.
So
All right.
one
I'll ask one question. Yeah, so very nice explanation for the basilar artery stroke, sir.
Yeah.
I want to ask you, because you are a very leading neurointerventionist, many a times in the cath lab suit, what we face is situations where we are in dilemma, like when we do for endovascular treatment, mechanical thrombectomy, there are tandem occlusions which are very significant, maybe an extracranial ICA occlusion, or for example vertebral artery stenosis as well, along with the basilar artery occlusion. So in these scenarios, what is your personal experience on how do you manage? Do you do emergency stenting for extracranial stenosis, which are very significant and prone to cause reocclusion or throw out thrombus and cause reocclusion? And how do you manage the antiplatelet medications? Because as per the tradition and the guidelines, antiplatelet medications are avoided for 24 hours post intravenous thrombolysis, where most of these patients are already at intravenous thrombolysis.
Yeah, that's a really great question, and as you mentioned, comes up frequently in practice. Tandem occlusions in the anterior circulation are, I would say, about 10% of all large vessel occlusions, and they're less common thanks to the posterior circulation, but I think they are in the about 2 to 5% range in the posterior circulation also, and the data from the sub-analysis of the RCTs, which are published, the randomized controlled trials, the landmark randomized controlled trials, suggest that unless you open the extracranial occlusion also, along with the intracranial occlusion, the outcomes are poor. And so this needs to be proven in focused randomized trials of tandem occlusions. And so we are in a study called Picasso that is looking at this. And also the study randomizes between angioplasty versus stenting, exactly to address the issue of antiplatelets. Because with angioplasty, you may not need heavy antiplatelet therapy. But my practice, based on the observational data and the retrospective studies, as well as the subgroup studies from the RCTs, is to have a very low threshold for stenting the extracranial occlusion in the carotid or in the vertebral artery. And the antiplatelet therapy, the way it's recommended, and there are 2 or 3 different approaches, but really you have to load the patient with either a GP2B3A inhibitor or a oral load of Brilinta as soon as you drop the stent or right before you drop the stent. So my practice is to open the carotid, for example, in the anterior circulation on the way up, so that I don't have trouble retrieving the clot through the occlusion. And so I open the carotid first with a carotid stent, and if it's feasible with a distal protection, I aspirate the carotid occlusion with a large bore catheter at the proximal end of the ICA, and most of the times it doesn't open, but we may aspirate some clot, and then we drop the stent first using the standard technique with a distal protection, and as soon as the proximal carotid is open, we go up and do a thrombectomy in the ICA terminus or M1, depending on where the occlusion is. And so the antiplatelet regimen or approach that I prefer is to use a OG tube. I do all my cases under general anesthesia, so the anesthesiologist team are able to put the OG tube for us and give Brilinta as soon as the stent is deployed, and then we do the thrombectomy and continue the oral antiplatelet regimen the following day. When we finished, we also give a per rectal aspirin, to improve the antiplatelet effect. So I try to avoid GP2B3A inhibitors in tandem occlusions to lower the risk of bleeding. And the data on oral loading with, in the past we used to use Plavix, but as you know, there are a number of non-responders, and that's why we use Brilinta, and the bleeding rates are reasonably low, the success I've had with this approach has been really quite good, with, I would say, stent patency rates above 90%. Even if I have to go back and do angioplasty electively for the stent, we find that the stents remain open, and we have the close to 30 to 40% rate of good outcome in the tandem occlusions with this approach. And this is anecdotal, and I'm just talking about my own experience. The new randomized trial for Picasso, and I believe there is some others also going on outside the US, I think will help us really standardize uh, the approach to tandem occlusions. But to summarize, you know, revascularizing the proximal occlusion with a stent or angioplasty is critical to really achieve a good reperfusion, which we know is the basis of a good functional outcome intracranially. So revascularizing the extracranial occlusion along with the intracranial occlusion is critical, with use of double antiplatelet therapy to keep the stent open.